Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center reporting for the week of September 18th, 2023. After a COVID status update, I'll go through some of the data and information that has helped to shape the new guidelines on the boosters, including some hospitalization and death data. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. COVID is still with us. It's still causing sickness, disability, and death, and there is a lot we still don't know. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Taking a look at wastewater, this graph shows the percentage of sites that have increasing or decreasing levels of SARS-CoV-2. And so this is about the percentage of sites across the country that are increasing or decreasing. And if you look all the way over to the right, just before you get to that shaded gray area, it does look like there's a bit of a downturn in the number of sites that are having increases. So that's the red and the orange areas. So from mid-August to the end of August, it looks like we're going down a bit, and this is reflecting over 1,300 different sites across the country. It's kind of a slight downturn, and unfortunately, it looks like it might be going back up again when you look at the gray shaded area, but that shaded area is incomplete, so we'll keep watching it. So the most complete data set we have here is through August 29th. That's still a few weeks old, which isn't great in terms of trying to get the early indication that I think wastewater promises to be. So this is why I'm always encouraging finding a site near you and just following that site and really drilling down into your area if you want to know what's going on where you live or maybe where you might be traveling, for example, because many of the sites are actually updating more frequently than this. For example, when we look here in Oakland, you can see that wastewater is updated through September 14th. So that's pretty good, just a few days old. This is from the Verily site, which is linked in the post. They have a number of different geographic areas. I've included several different actually wastewater sites that you can take a look at if this is something you're interested in. So here in Oakland, despite some zigzagging there over the past couple of weeks, it finally does look like it's coming down. So let's hope that it keeps going that way. And now taking a look nationwide at percent positivity, this just seems to keep going up. It's now at 14.3%. Also, the test volumes themselves are still higher than they were before. So more people are actually getting tested now. For much of July and August, the number of tests being conducted each week was kind of in the 40,000 area. But since late August, we've been more like 50 to 60,000 tests every week. Still a small number of tests being conducted, but it's more than before. So this percent positivity going higher is definitely not reassuring. As a reminder, in early June, we were just above 4%. So we're more than triple that at this point. And this data here is just a little over 1 week old. Now, for our most updated indicator, that's percentage of all emergency department visits with diagnosed COVID-19 in the US. And we have this data updated through September 15th. So also just a few days old. That's pretty good. And it is reassuring to see this coming down. So pretty much for the month of September so far, this metric has been trending down after reaching what looks to be a peak at the end of August. So I do feel very cautiously reassured by this, especially because emergency department visits, that is the most updated information we have. It's a little bit of an earlier indicator, certainly than hospitalization and definitely earlier than death. And it's the most updated information we have, and it's heading in the right direction. So what we want now is to see this decrease followed by a decrease in hospitalizations and deaths. And at that point, we'll have a real reason to feel relieved. Until then, it's just sort of one indicator going the right way, but we'll need some time to see if this is going to translate into real improvement in the severe outcomes we are concerned about. So something we will continue to keep an eye on. And unfortunately, though, we're just not there yet. Taking a look at hospital admissions, unfortunately, new weekly hospital admissions are just continuing to climb week over week since late June, early July. Unfortunately, we had 20,538 new hospital admissions for the week ending September 9th. So hospitalizations with or for COVID are currently more than triple what they were for much of June. So definitely still heading in the wrong direction. I will note that the rate of the increase in hospitalization seems to be a little less steep than it was the week before. It's 7.7% increase the week ending September 9th. The week before that, it was 8.7%. So not a whole lot better, but I guess we can take what we can get. And taking a look at deaths, these continue to increase as well. The week ending August 19th, there were 844 deaths. And it looks like they've gone up even further after that, but those data are still incomplete. So sadly, we are back over 3,000 deaths per month from COVID. And so far out of COVID deaths, 87% of the time COVID was the underlying cause of death, while the other 13% of the time it was a contributing cause of death. So this is real. This is probably our most reliable metric, is taking a look at deaths. And sadly, those are also heading in the wrong direction. And now taking a look at variant proportions, not a whole lot to report here. EG.5 is now about 1/4 of our specimens. Remember, despite that name, and actually despite all these different names here, they're all part of the XBB family. So we're still dealing with pretty much all XBB subvariants of Omicron, which is a good thing, especially since that's what the new booster is tuned against. So it's very important that the new boosters actually don't have any of the old strains in them. And the vaccines with the old strains have actually been deauthorized now and are in the process of being discarded. So, as I discussed last week, the monovalent vaccine was authorized by the FDA, and at that time, we were waiting for the CDC's advisory committee, the ACIP, to meet and discuss this vaccine and make recommendations, which they did do last week. They went over a lot of data and had a lot of discussion. So, for today, I just wanted to go over some of the pertinent parts, and then I will be discussing some of the other portions in future briefings. They talked about a lot of things. They talked about the current variant situation. They talked about what is going on with COVID currently. They talked about post-COVID as it relates to the vaccine. And that topic I am going to come back and discuss in a future briefing because there are some analyses that I think are worth reviewing. But the bottom line of that part of the discussion, so post-COVID as it relates to the vaccine, is that I think the bottom line is the effect of the COVID vaccine on long COVID is still not conclusive, but there is some indication that getting vaccinated before SARS-CoV-2 infection was associated or has been associated with a lower risk of long COVID. Now, there's kind of mixed data about vaccination after having long COVID. We really need to learn more about this. Now, there are some reports of people showing improvement, some reports of people showing worsening. These are, again, people with long COVID then getting vaccinated. And this probably speaks to the fact that post-COVID and long COVID is not one thing. So there's not going to be one treatment. And we will have another long COVID update soon. But in the meantime, suffice it to say, there is some evidence and kind of increasing evidence that vaccination before COVID infection is associated with a lower risk of long COVID. So we've still got a lot to learn here, but this is a consideration, particularly for those who do not have long COVID and wanting to know about ways to prevent it. Then each of the manufacturers presented data on their monovalent vaccine. So that was Pfizer, Moderna, and also Novavax. So even though Novavax isn't approved yet, my understanding is that having presented to the ACIP already, this means that once it does get that green light from the FDA, it won't need to come back to one of these big meetings, and instead it can hopefully be approved pretty quickly. And I'll come back to discuss more about this data, including Novavax, in a future briefing as well. But I think the bottom line here is that the data that was shared looked basically as expected, no surprises. We saw some animal data, we saw some human data. And at this point, I can make a general statement that there don't appear to be any bad choices. Each of the choices looks adequate. Each is tuned to the XBB subvariants of Omicron, so they're all relevant to the current strains. I really wish we had any head-to-head data on these vaccines, but we just don't. Hopefully sometime in the future we will. So I think the decision on which one to get is going to be an individual one, and I'll touch on that a little bit more in a moment. But first, I want to go over some key takeaways that the committee used to make their decision. They used the same framework to approach this that they've been using all along, the evidence to recommendations framework, which asks a number of questions. It asks about the importance of the public health problem, the benefits of the intervention, how feasible it is, how acceptable it is, how necessary it is, whether it's a good use of resources, and whether it's going to be equitable. And I'm going to mainly cover that first question, which is the problem of public health important? So is this important enough for us to be even having an intervention? And here are some of the key takeaways in evaluating that question. So first off, we take a look at the burden on children. And this slide is looking at COVID-19 associated hospitalization rates among children 6 months to 17 years old. And you can see here that children have not been spared. They have had COVID-associated hospitalizations. This is a burden we hate to see, and I think any parent who's had a child hospitalized can attest to that. And as we can see here, all age groups are affected, but it's those 6-month to 2-year-olds who are the most affected. And one thing we hear a lot, which I find a little disturbing, but I'm going to repeat it anyway because it's misinformation that needs to be corrected. And you hear people say, well, those were kids with underlying conditions, or those kids were sick anyway. Not true. Not true. In fact, you can see here on this slide, and first take a look over to the far right, that 54%, so over half of hospitalized infants, children, and adolescents under 17 or 17 or under have no underlying medical condition. 54% of hospitalized infants, children, and adolescents have no underlying medical condition. And note, you can see this at the real small print in the bottom, this data is really looking at where COVID-19 is likely the primary reason for admission. So this is not an incidental thing. This is why they were likely in the hospital, and over the half of the time, they had no underlying medical condition. This is very significant. And I know this is a busy slide, so just bear with me. We're just going to try to walk through this. So if you look over to the far left, the group of bars there at the far left, you can see that 75% or 3/4 of the children that were 6 months and under had no underlying conditions at all, 75%. If you look at the bars there, that is speaking to the 25% who did have an underlying condition. And you can see that the number one underlying condition in that age group was being born premature. So this is not really an uncommon thing. This is not some rare underlying condition, but this is something that we see frequently enough. And remember, 75% of the time they had nothing underlying, but they still ended up in the hospital with COVID-19 as a likely primary reason for admission. And the other 25% who did have something going on, the main thing they had going on was prematurity. And then when we take a look to the 6-month to 2-year-old babies, children, we can see that almost 60%, so 59% had no underlying condition. Once again, those who did have an underlying condition, the main one by far was prematurity. Again, having been born premature, but still being the most common underlying condition in those who had an underlying condition for those being hospitalized for COVID-19. And then as we get into the older age groups, so looking at the 2-year-olds to the 17-year-olds, so those 3 more groups of bars over to the right, and we can see here that the most common underlying condition in those who had an underlying condition was asthma most of the time. And then in the older age group, we see some neurologic conditions, and then we also see obesity in that purple color. So asthma and obesity, these are really common amongst our children. So majority of the time, no underlying medical conditions, but when we do have an underlying medical condition, we're looking at prematurity, asthma, obesity, things that are not uncommon in children in the United States. So really important to consider. Now, what about the vaccination status of these children who do get hospitalized? Well, as we can see here, in each age group, about 90% were not fully vaccinated. So the orange bar is unvaccinated and the dark gray bar is unboosted. So in each age group, 90% or more of those who are hospitalized for COVID were not adequately or fully vaccinated. And this is really important. It's a very important consideration when it comes to decisions to vaccinate children, because we really want to avoid children getting sick enough to go to the hospital, especially when we can absolutely do so with a simple vaccine. And we'll talk about this a little more in a moment. But first, let's talk about adults. Adults is a very different picture, where many of the adults that have been hospitalized have multiple underlying condition. And this varies to some extent by the age group, but high blood pressure, which is part of that green bar there, obesity, the pink bar, and diabetes, which is that dark gray bar, these are among the top underlying causes for adults who are hospitalized. And once again, these are data looking at where the hospitalizations, where COVID is likely the primary reason for admission. So we're not talking about people who went to the hospital because of their diabetes and then they got diagnosed with COVID, but their admission is really around COVID-19. So this is significant and important because a huge percentage of adults in the United States actually have an underlying condition. So whether they know it or not, whether they want to think of themselves as having underlying conditions or not, hypertension, diabetes, obesity in that pink bar, these are all quite common in the United States. And once again, when we look at the vaccination status among adults hospitalized for COVID, we can see that generally speaking, about 80% or more were unvaccinated or unboosted. And I find it quite concerning that when you look at the bar on the left there, that it's closer to 90% in the 18 to 49-year-olds. So once again, we know that we can prevent quite a bit of hospitalization with both children and adults by being vaccinated and boosted. Now, quickly regarding patients going to the ICU, if you take a look at the column to the far right there, we can see that over half of children, again, from 6 months to 2 years old that went to the ICU for COVID had no underlying condition at all. This is really devastating for any child. If you have a child who you think is healthy, they get a very common now airborne virus and end up in the ICU. And over half the time, they had no underlying condition when we look at that 6 month to 2 year old age group. And we look at the 2 to 4 year olds, it's about a third of them had no underlying conditions. Now, going to the ICU is very serious, and we see this type of vulnerability. We certainly want to take steps to intervene. And we can see that going all the way up to the 49-year-olds, there's significant portions of people who don't have any underlying conditions yet. They get sick enough from COVID to end up in the ICU. And some of these ICU stays can be lengthy, and it can take months or longer to really recover from these stays. So this is not just a benign, by the way, oh, you didn't die situation. This can be very significant, and it can cause morbidity or sickness or a deterioration in your status over time. And so this is not something that we want to be minimizing. And trying to take a closer look at deaths in young people. This isn't perfect because this is only looking at COVIDnet, which is just one of the surveillance systems that they look at, and it's kind of incomplete, but at least they were able to determine for this subset of young patients under 17 who did die, that half of them had no underlying condition. So once again, we're seeing a theme here. Half of these children in this subset of children 17 and under who died from COVID had no underlying condition. So I think it's really time we put that piece of misinformation to rest, particularly when we are talking about our children and really any age group. You do not have to have an underlying condition to get very sick or die with COVID. That's one of the most frustrating things about this virus, is that it has been very unpredictable from the beginning. It is not like the flu where we roughly can predict who may succumb to flu at the extremes of age and so on. Just isn't the case with COVID, unfortunately. And so really everyone is potentially at risk, even without any underlying conditions, even without being elderly and so forth. And if you want to think about this in terms of other things that we routinely vaccinate children for, take a look at this slide, which shows several pediatric vaccine preventable diseases. And so this is looking at deaths per year in the United States prior to the vaccines being available. So what this graph is trying to get at is we made decisions to vaccinate children against these diseases based upon the average deaths prior to the vaccine being available. And if you look at the bottom row there, every single one of them absolutely pales in comparison to the level of death we saw with COVID-19, which is the one in the bottom right corner there. And yet, these are all important vaccines. The vaccines are safe and effective. They can prevent hospitalization, ICU admission, and death. They also reduce transmission. So they reduce the circulation of these viruses so that we won't keep having unmitigated transmission and having more people getting sick. So seeing the number of childhood deaths over to the right there, just in 2022, just before the vaccine was available for the respective age groups, it seems pretty crystal clear that a vaccine to prevent this would be recommended. And for those still saying COVID is the flu, well, we know that that is absolutely not the case. I went into a whole lot of detail about this in a prior briefing, which I linked in the post, especially for those of you who might still be contending with people in your circle trying to say it's the flu. There's about 15 ways it is not the flu, and this is one of them. Taking a look at COVID versus flu-associated deaths in children by age group and by year. The dark gray is COVID, the kind of bright blue there is influenza, and any way you look at it, any of the age groups, any of the time frames, you can see that COVID sadly blows away influenza, just blows it out of the water any way you look at it, every year, every age group. And again, this is deaths associated with infection in people 19 years or younger. After weighing out all of this information and much more, the question before the committee, the ACIP, was basically, should the 2023-24 monovalent XBB containing COVID vaccines be recommended for use in persons 6 months of age and older? And they ultimately voted 13-1 in favor of this. The no vote was from Dr. Pablo Sanchez, and Dr. Sanchez expressed his preference to focus the vaccine efforts on those most at-risk groups, so those who are 65 and up, immunocompromised, those who are pregnant, saying, and I quote, "I'm not in favor of a universal mandate." I don't think a mandate was part of the discussion at all, so I'm not sure whether this was more of a concern about the future and what will be required in the future. But for this meeting, they were contemplating recommendations, not mandates. And for now, it seems like there is a lot of support for leaving it open, and I think there are a few reasons. One was just to simplify things. We can all remember the tiers and the phases of eligibility that have happened at different times in the rollout. They're frustrating, they're confusing for everyone. And now that I think we anticipate ample supply, there's kind of a sentiment that we should just keep it simple and available and accessible. And secondly, is that in the United States, when you start putting eligibility restrictions on things, it can become a reason or an excuse why insurance companies will decline to cover it. So we don't want to get into a situation where insurance companies are gatekeeping this vaccine, particularly when the benefits have been illustrated. And this can be done in conjunction with a physician who will not have to worry about this being denied or the patient ending up with a bill and so forth. So we really just don't want to see that happen, especially since it's still being transmitted and it's still a public health concern. So I think we all want to see this, the transmission of this, slowing down. And this is one of the ways that we can do that. Definitely not the only way, but it is one of the ways. So overall, this does seem like a reasonable way to go. Certainly, we do still want to acknowledge that there are groups that should absolutely be protected, for sure. So those over 65, those with underlying conditions, those who are pregnant, and it's both for themselves because they do have higher morbidity, so they can have bad outcomes by the state of being pregnant and getting COVID and not being vaccinated. But it's also for their babies who can't get vaccinated until they're 6 months old. And we've already seen that the little ones are vulnerable to bad outcomes if they get COVID. So these are folks who should get to the front of the line, so to speak, especially if they have not had a vaccine for over 2 months or they haven't had COVID for over 3 months. But as we've reviewed, all age groups can potentially get sick enough for hospitalization or worse. And even those who have the underlying conditions, these are fairly common. So pretty much this is something that is available to you. There's not a whole lot by way of downside in getting these vaccines. They have been remarkably safe. They do reduce your risk of getting and transmitting COVID, not nearly as much as we would like them to, but they still do. And they may even reduce your risk of getting long COVID, even in the event that you do get COVID. So in summary, all indications continue to go up with the exception of emergency department visits, which is our most up-to-date metric. So I'm still saying this might be an early sign of improvement. We will need to wait and see if hospitalizations and deaths start to come down as well. The mRNA monovalent vaccines that look to be effective against the strains that are circulating now are starting to become available as we speak. The bivalent vaccines are now deauthorized, and we are still waiting for the Novavax monovalent to be approved. Now, I will say that with the commercialization of the pandemic response, the federal COVID-19 vaccine program has ended. So we're all having to shift the way we obtain our COVID-19 vaccines. The Bridge Access Program will be providing no-cost vaccines for uninsured and underinsured individuals, but supplies and locations will be more limited compared to prior rollouts. At Roots, we're still awaiting information on how many we'll get, on when we'll get them, on what brand we'll get. And we do anticipate having them, or at least knowing when we're going to have them in the coming days. For those with insurance, your primary care providers will be needing to purchase these vaccines like they do with other vaccines. So it just might take a moment for everyone to settle into this new way of getting on board and having these vaccines available. It is probably worth checking with your primary care provider about when they intend to get them. This does not seem to me to be something that should be optional for any primary care provider, but in the event that your primary care provider is not going to purchase and carry them, they need to tell you where it is that you can go to get them. You can check vaccines.gov. They do have a lot of things listed there. They're mostly all CVS's and Walgreens listed there. But we would strongly suggest calling the actual pharmacy in your neighborhood, the one that you want to go to check availability, since we have been hearing stories of them not having what's listed or running out sooner than they thought. So I hope that everyone who needs or wants the booster will be able to access it soon. I will talk more in future briefings about timing as it might relate to the flu vaccine or the RSV vaccine. But really, for those in the high-risk categories and no COVID in the last 3 months or no booster in the last 2 months, the recommendation is that you get your monovalent as soon as you can access it and get whichever brand you can access sooner. And we're not sure yet if waiting for the Novavax will be a good strategy for anyone. Of course, if you were allergic to the mRNA, to both of the mRNAs, or if you really absolutely have a contraindication, a real one where you cannot take the mRNAs, then it might be a good strategy perhaps to wait for the Novavax. But I think this is something to discuss with your primary care provider. And other than that, I think the recommendation is going to be similar to how it's been all along, which is to get the one that you have access to, essentially. And in the meantime, with cases rising and still rising hospitalizations and our protection wearing off from the last boosters that we've had, we really do need to be more vigilant to prevent infection, reinfection, and spreading it to others. There is mounting evidence of the cumulative effects of repeat infection. There does not seem to be any limit to the number of times you can be infected. We are seeing many post-COVID and long COVID consequences, and these include pretty much almost any organ you can think of can be affected. We've seen new diabetes, we've seen worsening asthma, we've seen blood clots, heart attacks, strokes, we've seen neurological issues, memory issues, and so on. And it's just because you had it once and you did fine doesn't mean that's a guarantee about next time. Sometimes we're seeing these bad outcomes or post-COVID events happening after the second time or after the third time. It's just still very unpredictable. And sometimes the repeat infection can be milder the second time, but sometimes it can be more severe, even in that acute phase. And every infection is a new opportunity and maybe even a compounded opportunity for long COVID and post-COVID impacts. Let's keep up our best practices to prevent the spread of COVID and prevent outbreaks. No one layer is foolproof, so we want to implement layers of protection. Stay up to date on vaccination, wear a high quality filtration mask like N95, KN95, or KF94 when you're indoors with others, and even if you're outdoors and cannot maintain spacing. But whenever possible, do gather outside, which is almost always safer than inside, but it is certainly not 100%. And if you're going to be indoors, you'll want to monitor and improve indoor ventilation and filtration. If you're someone who should be treated if you catch COVID, then you should know in advance and you should have a treatment plan. Treatment can reduce the risk of hospitalization or death by over 80% if you start it on time. And this is a list of the available outpatient treatments. So these are ones that you need to get ASAP. If you start to have symptoms, you need to get tested. And if you get tested on time, then you can get treated on time. As you can see, you have a small window where you can start treatment, and this can prevent a lot of the hospitalizations and deaths that we're seeing. And one of our viewers provided an excellent amendment to this, which is that you should also have a child care plan. A child care plan should be in place. We know this can get complicated depending on who all gets sick, who all needs to isolate and quarantine, the ages of the children, and who's going to take care of them, and who's going to take care of the sick people too. And I think every household should have a supply of N95s in the home in event that you do need to mitigate household spread. I've linked our 2-minute video about avoiding household spread in the post, so please check that out. If you don't feel well, please stay home and rest. Don't spread what you've got to others. If you are positive for COVID, please test negative before you go back around others. In general, when it comes to those antigen tests, enough virus to detect is enough to infect. If you don't have a primary care provider, please get one. Know how to reach them before you need them. Remember to eat a balanced diet, incorporate whole grains and vegetables, and avoid those sugary drinks. Consider a multivitamin supplement. Get some regular physical activity unless you're sick. In that case, please get your rest. Get your blood pressure checked. Get your baseline labs checked like sugar, cholesterol, vitamin D. Manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.